Today we'll start general surgery. The first topic that we are going to discuss is Paget disease of breast and nipple. What is Paget disease? Paget disease is basically a rare breast malignancy. The feature of Paget disease is eczematous changes, eczema-like changes around the areola and inverted nipple. When invasive ductal carcinoma or ductal carcinoma in situ involves the areola or the nipple, then it is known as Paget disease of breast and nipple. What are the features of Paget disease? Paget disease will present to you as eczematous changes around areola with scales, erosion. What are eczematic changes? Eczematic changes means dry skin with itching around the areola. And as it is a breast malignancy, so there will be discharge from nipple as well, which is sometimes bloody, ulcerated, or inverted nipple. So, a female with eczema like changes around her areola or dry itchy skin with scales and a bloody discharge from nipples and inverted or ulcerated nipples. And the diagnosis is most likely Paget disease of nipple or breast. The diagnosis is made by punch biopsy. What is punch biopsy? In punch biopsy, a circular tissue is taken by using a needle which is also circular in shape. What are the other common breast lesions? Now, the first of them is nipple abscess or breast abscess. Abscess is always painful, so painful fluctuating mass over the breast or near the nipple, then it is most likely breast abscess or nipple abscess. Remember that in surgery, the treatment of abscess is always incision and drainage plus antibiotics. If you do not drain the abscess, the patient's symptoms will not improve no matter how much antibiotic you give to the patient. Now, the second one is ductectasia. Ductectasia, what is ductectasia? In ductectasia, basically, there is a local dilatation of the uh, mammary ducts. It is a common condition in women who are near to menopause. So, ductectasia is common in old age females who are near to their menopause. There will be brown green color discharge from nipples in a female who is near her menopause. The diagnosis will most likely be ductectasia. Now, history of trauma to the breast, and the patient present to you after a history of trauma to the breast with a firm, round, solitary, and localized lump. Remember that lump in breast in an old woman, you need to rule out breast cancer in all the cases. But if they ask you about the diagnosis of this patient in which there is a history of trauma and she present to you with a lump in her breast which is round and firm, and also there will be bruises or redness. So history of trauma is the main hint, after which the female will develop a localized lump which is solitary and firm with redness and bruises. The diagnosis will most likely be fat necrosis. Bleeding per nipple in a young female of 20 between 20 to 40 years old with skin changes, the diagnosis will most likely be ductal papilloma. So ductal papilloma is common in premenopausal women or menstruating women, and duct ectasia is common in women who are near their menopause. So if the patient age is around 50 or 45 and she present to you with discharge from nipple, green or ground color discharge from nipple, then it is most likely duct ectasia. While duct papilloma is common in younger women, there will be bleeding per nipple and it is diagnosed by galactogram. Ductal papilloma is diagnosed by galactogram. Galactogram is different from mammography or mammogram. In galactogram, a dye is injected or a contrast media is injected into the ducts of the mammary gland, and then X-rays are taken. So basically, because it's the problem with the duct, benign tumor of the ducts of the mammary gland, so we need to visualize the duct, which cannot be visualized clearly on mammogram. So that's why in ductal papilloma, investigation of choice will be in galactogram.
I have a question.
Yes.
Um, so sometimes, they tell us to look out for skin changes on the breast and like bleeding and sort of things to diagnose breast cancer. So how
Yes.
will you, as a
Yes. Yes.
clinician, point out specifically that this is not breast cancer, but it's ductal papilloma? Because you can be 35 and still have breast cancer. And I see um, the age range here is 20 to 40 years. So just a little clarity on that, maybe.
The changes that are present in breast cancer, there will be other hints to you like lymphadenopathy, and also there will be a lump which is irregular, firm, and hard. Also, there will be history of weight loss and the skin changes. There are specific skin changes in breast carcinoma. For example, in breast carcinoma or invasive ductal carcinoma, if they block the lymphatic drainage of the breast, it will result of the skin like a
Like
peel
an
of an
orange.
orange. Yes, which is called
Okay.
UD orange appearance of the. So for breast carcinoma, there will be other hints like lymphadenopathy and an irregular firm mass or lump. And breast cancer is uh, less common in this age duration.
Mhm.
So these are the hints on the basis of which you can specifically pinpoint towards breast carcinoma.
Okay, got it. Thank you.
So bleeding discharge by nipple in an old woman with eczema-like changes. So eczema-like changes is always pleasure disease. Eczema-like changes or around the nipple or areola or ulcers, it is Paget disease, which is diagnosed by punch biopsy. Now, firm, non-tender, mobile mass in a breast of a young. Remember that the mass which is present in breast carcinoma, that is always fixed and not mobile. So if a young female present to you with a mobile mass which is non-tender, then it is most likely fibroadenoma. Because in breast cancer, the mass is always fixed. So the clinical diagnosis of fibroadenoma is made by these features, that the mass in fibroadenoma is mobile. And what is the investigation? First, we will perform ultrasound and then FNAC, fine needle aspiration. Now, breast pain and increase in the lumpiness or nodularity of the breast in the reproductive age, which has an association with the menstrual cycle. Breast pain and nodularity that appears just before the menstrual cycle and disappears after it. The diagnosis is most likely fibroadenosis. Breast pain, only breast pain that is intermittent and no association with menstrual cycle, it is called non-cyclical mastalgia. Breast pain without any nodularity or lumpiness that has an association with menstrual cycle is cyclical mastalgia. So three differential diagnoses of breast pain. Breast pain plus increased breast size or lumpiness just before the menstrual cycle is fibroadenosis. Adenosis means formation of or hyperplasia or formation of glands, and fibro means fibrosis. So for fibroadenosis, along with pain, lumpiness is also required to make a diagnosis. But if a female complains only of pain without any lumpiness, which has an association with menstrual cycle, then it is cyclical mastalgia. And if no association of pain with menstrual cycle, then it is non-cyclical mastalgia. So fixed, irregular, hard, painless lump. See, this is what I was talking about, that the mass or the lump in the breast cancer will be fixed. It will be irregular. There will be nipple retraction, UD orange appearance of the skin, and lymphadenopathy, because the lymphatics from the breast is drained into the axillary lymph node. So the lymph nodes will also be fixed and firm in consistency. So these are the features of breast cancer. Breast cancer is diagnosed by core biopsy. Offensive yellow discharge from an area near the nipple, history of abscess. Yellow
Sorry,
discharge.
just a question about the punch biopsy and core biopsy. Is it like for any of the breast cancer? First, it's the core biopsy, and for the Paget disease, it's specifically punch biopsy.
Yes, for Paget disease is specifically punch biopsy.
But
Because
for
in
any,
punch biopsy is just like you can imagine that, like if when we take a scoop of ice cream, punch biopsy is like that we punch or a circular tissue. While in core biopsy, a true cut needle is used. In punch biopsy, the needle that is used that is circular in shape, while in core biopsy, a true cut or core biopsy needle is used, and that takes some tissue from suspected lump.
So in punch biopsy, it doesn't take tissue, or it takes a bigger tissue, and in core biopsy, it takes
Big,
smaller.
punch biopsy, you can say that the punch biopsy takes the skin, the epidermis, the dermis, and the tissue from
Right.
underlying the areola. While in core biopsy, you can say that the needle is inserted, the true cut needle is inserted in the suspected lump, and from where tissue is taken. So tissue is taken in the both of the biopsy. The
Okay.
name is different because the needle that is used to take the biopsy is also different.
Right. So whenever a cancer of the breast is suspected, the first thing they do is like the needle biopsy, and then go for the punch biopsy. Or
Yes, initial fine needle aspiration can be done, but to diagnose or the most definitive diagnosis is made by core biopsy.
okay, that's fine. Thank you.
So yellow discharge from an area near the nipple. Usually there is discharge from the nipple, but in this case, there's a yellow discharge from an area near the nipple. Yellow discharge means it is a pus. So also there will be history of abscess in this area. It is most likely because there is a discharge from an abnormal place. So a fistula is most likely has been formed, due to which this yellow discharge is coming out of the fistula. So yellow discharge with the history of abscess, diagnosis will be rectal fistula. Remember that this yellow discharge is not from the nipple, but an area near the nipple. Prolonged redness around the areola. History of using antibiotics which improve symptoms slightly. Greenish discharge per nipple, plus nipple retraction plus small lump around the nipple is felt. So the first hint is prolonged redness around the areola. Redness means inflammation, because the signs of inflammation include redness, pain, heat. So prolonged redness around the areola with a history of using antibiotics for the condition, for the same condition, for the redness, which improved the symptoms slightly, and also greenish discharge per nipple, then it is most likely periductal mastitis. Periductal, remember that periductal mastitis is common in young females and also in lactating women. All the infections of the breast are common in the lactating woman, such as breast abscess or periductal mastitis. Risk factor for periductal mastitis is smoking. Treatment is antibiotic, and if left untreated, it can develop into abscess. And as I told you before, that whenever there's abscess formation, you need to drain the abscess along with giving antibiotics.
So, what is the difference between fistula and periductal mastitis?
In fistula is, you can say that an abnormal communication is formed between the skin of the breast and the inside tissues. You see that in fistula, the discharge is not from the nipples. The discharge, whatever the color is, this is the biggest hint for fistula, that the discharge that is coming out is not from the nipples. It's from an area near the nipple.
Right.
While in periductal mastitis, you can see that mastitis, inflammation, so redness, prolonged redness, and the greenish discharge is from the nipples and not in an area near the nipple. Is it clear?
Yeah, yeah. Thank you.
Now, what is the answer or what is the diagnosis of this scenario? Written at the bottom of the page.
Zinger diverticulum.
Yeah, pharyngeal pouch.
Pharyngeal
Yes,
pouch.
it's Zinger diverticulum or pharyngeal pouch. You are right. To diagnose pharyngeal pouch, the investigation of choice is barium, swallow, and not endoscopy. Now, what's the answer of this one? Old age, gradually worsening dysphagia, initially for solid food and then for soft and liquids, long standing gastric reflex.
Esophageal cancer.
It's esophageal
Yes, that's right.
Esophageal
stricture.
stricture.
Gradually worsening dysphagia, initially for solids, food, and then for softs and liquids, plus
Is it
long
Barrett?
standing reflex.
Esophageal stricture because there's long-standing gastric reflux.
Yes, long standing gastric reflex can lead to Barrett esophagus and as well as in esophageal stricture. One thing that is not favoring esophageal stricture is the age of the patient. Though no history of
Not
weight loss is given, but the patient is old age. So long-standing gastric reflux, because of old age, we will choose esophageal carcinoma. So what are the type of esophageal carcinoma? What are the types of esophageal carcinoma? Anyone?
Squamous cell, columnar cell, like this.
Squamous
Squamous cell
cell
carcinoma
and
adenocarcinoma.
adenocarcinoma.
So if we say that this patient is having esophageal carcinoma, which one it will be?
Carcinoma.
Which type of carcinoma is common in patient of long-standing gastric reflex?
That should be squamous cell.
Barrett esophagus is from upper two-third, lower one-third. So upper two-third is adenocarcinoma and lower one-third is squamous cell carcinoma.
So I have told you the meaning of adeno. What does adeno mean? It means a gland. What happens in Barrett esophagus that the epithelium of the lower one-third is changed from squamous into columnar. And columnar epithelium has mucin secreting glands or goblet cells, you can say. So gastric reflux is a risk factor for adenocarcinoma. What are the risk factors for squamous cell carcinoma of the esophagus?
Regurgitation,
Regurgitation in which condition?
eclasia,
Tell me the name.
eclasia.
Yes, eclasia is a risk factor for squamous cell carcinoma, as well as smoking is also a risk factor for squamous cell carcinoma. So GERD, the most common esophageal carcinoma is adenocarcinoma. The risk factor for adenocarcinoma is long-standing GERD, and the risk factor for squamous cell carcinoma is smoking and eclasia. How to diagnose esophageal carcinoma? A hint on barium swallow will be proximal shouldering, irregular narrowing, and proximal shadowing. Let me show you a diagram. Can everyone see the diagram?
Yes.
Yes.
So on barium swallow, see there's a defect here and narrowing of the esophagus, and this is proximal shouldering of the esophagus. So on barium swallow, in case of esophageal carcinoma, there will be irregular narrowing of the esophagus plus proximal shouldering. Another hint will be weight loss, which was not given in this scenario, but considering the age of the patient, we favored more esophageal carcinoma. But it could have been esophageal stricture if the patient age was young. The commonest type is adenocarcinoma. By the diagnostic investigation or the gold standard to diagnose esophageal cancer is upper GI endoscopy plus biopsy. Adenocarcinoma is common in GERD and Barrett esophagus. GERD leads to Barrett esophagus, and Barrett esophagus can lead to adenocarcinoma. Now, some common tumor markers. You just need to memorize all of those. Now, gastric carcinoma is also already discussed. Left supraclavicular mass is always gastric carcinoma in a patient with old age, with weight loss and vomiting dyspepsia is always gastric carcinoma. Kindly mute your microphone, everyone. So if gastric carcinoma, a left supraclavicular mass present to you with hepatomegaly and ascites, then most probably the gastric carcinoma has metastasized to liver, which have resulted in the formation of ascites. Risk factor for gastric carcinoma include H. pylori infection, pernicious anemia, spicy food, smoking, old age, and blood group A. Now, hemoglobin level before surgery. There was a question on this topic in the November Plab 1. So, what will you do if a person has anemia in case of elective surgery? When you will defer or postpone the surgery. If the HB is less than 10, in case of elective surgery, then you will postpone the surgery and investigate for the anemia region. But if HB is less than 8, then it's an indication for blood transfusion. So you will transfuse blood and defer the surgery. While in case of emergency surgeries, if HB is less than 10, then you can proceed with the surgery. And if HB is less than 8, then transfuse blood and proceed with the surgery. Now, hypercalcemia. What are the signs and symptoms of hypercalcemia? Can anyone tell me, if there is high calcium in the blood, what will happen?
Is bone pain. There will be polydipsia, polyuria, and confusion, and constipation.
Yes, constipation as well, because it will lead to spasm of the GAT muscles. So yes, abdominal cramps or constipation can also occur. And as it is involved in the neurotransmitter transmission, so it can lead to confusion and depression. And as there is osmolarity of the plasma is increased, if there is high calcium in the plasma, so there will be increased thirst and polyuria. What are the common conditions which can cause hypercalcemia? Primary hyperparathyroidism can cause hypercalcemia and related to surgery. Which are the cancers which can metastasize to bones? Breast cancer, prostate cancer, and multiple myeloma. Breast cancer and prostate cancer, they can metastasize to bones. The most common cancer in the females that metastasize to bone is breast. So why in lung cancer there's hypercalcemia? Can anyone tell me? Which lung cancer is associated with hypercalcemia?
Small cell carcinoma.
Squamous cell, I think. Squamous cell carcinoma.
Yes, it's squamous cell carcinoma. Small cell carcinoma is associated with, remember that the hormones that start with A, they are secreted by the small cell carcinoma that start with the letter A, such as ACTH and ADH. Both of them are secreted by the small cell lung cancer, while squamous cell carcinoma secrete parathyroid hormone, which can lead to hypercalcemia.
Okay.
So manifestation we have already discussed. The ECG manifestation is hypercalcemia is of short QT interval. The causes are also discussed. So can anyone tell me, they have mentioned here sarcoidosis can also lead to hypercalcemia. Can anyone of you remember the cause of hypercalcemia and sarcoidosis? In sarcoidosis, non-quiescent granulomas are formed, which consist of macrophages or giant cells. Which secrete an enzyme which is known as alpha hydroxylase. Alpha hydroxylase leads to the increased formation of vitamin D. That's why there's hypercalcemia in sarcoidosis.
Sir, can you repeat this again?
In sarcoidosis, you know that granulomas are formed, and the composition of granulomas are formed due to macrophages. So the activated macrophages in sarcoidosis excrete or form an enzyme which is called alpha 1 hydroxylase, and alpha 1 hydroxylase is required for the formation of active form of vitamin D. So due to this enzyme, excessive activation of vitamin D leads to hypercalcemia, because vitamin D will lead to the absorption of calcium from the GIT tract as well as from renal cells, so renal tubules, so it will lead to hypercalcemia. The initial management of hypercalcemia is IV fluids. Is it clear? clear, Dr. Sumbal?
Yes, sir. Thank you.
The initial management of hypercalcemia is initially will give IV fluids, and then the specific management is bisphosphonates. Remember that the mechanism of action of bisphosphonates is that they decrease the calcium resorption from the bones. The osteoclastic calcium resorption of the bones is decreased by the bisphosphonates. So initially IV fluid, and then we need to give bisphosphonates for the management of hypercalcemia. Now, there is a clinical scenario. Let's see what it is. Sudden onset of severe left lower abdominal pain. So left lower abdominal pain develops to generalized abdominal pain, guarding and rigidity, plus fever, plus tachycardia. So can anyone tell me which organ of the, or which part of the GIT tract or enteric tract is present in the left lower abdomen?
Sigmoid colon and rectum.
Yes, rectum, sigmoid colon, and descending colon.
Descending.
So,
Yes.
so we can say that in this scenario, there's a problem with the colon, sigmoid colon or descending colon.